Hello. Thanks very much. It's a pleasure to be here. It's quite a long way from Western Australia where there are floods at the moment. Australia's a funny continent. We've got heat waves on one end and floods on the other. That's sort of a bit like America, I suppose, similar size. It's been fun to run the workshop. It's always a privilege to work with people who are suffering from pain and to hear their story and to kind of try and set them on a journey. And that's kind of been my great interest. As a researcher and a clinician, I kind of sit in these two worlds. One is the world of research where we have a hypothesis and you investigate. You set a plan and you investigate a question, and you always find something you didn't think was going to be there. Very often, in almost every research project I've been involved in, you think you know the answer and you look at the data and it doesn't actually hold up, and it makes you realize that we're massively driven by our beliefs. So often our beliefs are just a construct of our culture, of our background, of our own personal pain experiences. And when you look at the data, the danger is to interpret your data through your own belief system, and sometimes that just doesn't fit. And so I've been very fortunate to work with a wonderful team of people to investigate the issue around pain, and we've been particularly involved in back pain, but also in other parts of the body, and to look at the development of pain across time, across the lifespan, to look at the factors that predict pain, to look at the things that are associated with pain, and then to look at how modifiable those things are in terms of shifting the journey of people we work with. And I think the thing that strikes me more and more is that so often pain is iatrogenic, that we actually have a health system that creates a monster. We have a health system that tells people that pain is because they're damaged, that there's something wrong with their body, that there's something broken, that they need to protect it, that the way you treat it is to treat the symptom of pain, to chop it, to inject it, to push on it, to jab it. And so often what that leaves the person with is no strategies to control pain for themselves. And so they become caught in this vicious cycle of becoming frightened, losing confidence, becoming disabled, and so often they fall back on the things that they're told, which is to protect their bodies, to guard their bodies, and it leaves them trapped. It's pretty sobering when you start listening to the stories of people with pain, because you'll hear that the devastation that can have on people's lives, on their mental health, on their social capacity, their work capacity, and that can set a trajectory that for many people they can't get off. And so, we have a huge challenge, I think, as health professionals to actually change that story, and it's really hard because we've got an industry that is fighting us, an industry that's making a lot of money from people's pain and suffering. And so often that industry is interested in not the outcomes of the individual, but often the financial benefits that go with providing a service. So with that in mind, I want to share you the story of a man who I saw a couple of years ago. And this was interviewed by one of our health reporters in our national radio. His name was Martin.
On the floor at a school camp. Then it got progressively worse over a period of 2 years.
Take that back.
2 years ago, I had my first back pain. It was as a result of sleeping on the floor at a school camp. Then it got progressively worse over a period of 2 years. I was seeking help from my GP and went through a variety of different specialists trying to find an answer for it.
And how badly was it affecting you?
Well, it was affecting all of my movement. I was very guarded in any movement that I made. I refrained from lifting, and it got to the stage where any sort of bending was difficult and was something that I completely avoided.
Were you in pain all the time?
Pretty much. It would get progressively worse as the day went on. So I'd wake up with some level of comfort, but by midday it was quite painful, and at night it was severe pain.
So it was knocking you around a fair bit?
Yeah.
What treatment were you having?
Initially I started to visit my physiotherapist, but that would give me relief for a very short period of time and no ongoing benefits. Then I was referred to a surgeon who got me to get an MRI, and he pointed out the areas of my back that weren't looking quite right. There was some arthritis beginning, and there was some issues with the facet joints, but he didn't think that any kind of surgical intervention was actually going to give me much relief. So then he referred me to a pain specialist to get a cortisone injection, and I had 2 of those, and they were reasonably successful, but again only for a short period of time.
So that's a pretty common story. This is someone who develops pain from sleeping on the floor of school camp. Now that's probably not the common bit, but the common bit is that he didn't have an injury. So this is someone who develops back pain with no injury, and we so often presume that pain is linked to injury, but if you actually ask people with back pain, can they think of an incident or an injury, very often they can't. In fact, more than over half of people can't really think of anything that could in any meaningful way create tissue damage, and yet we treat pain like tissue damage. So, typically this guy seeks a physiotherapist, didn't get relief, goes to see the doctor. What does the doctor do? Gets a scan. What's he got? He's got a degenerate disc. Well, how common is that? All of us have got them. But that becomes his diagnosis. Why? Because we believe that pain is linked to structure. And we look at a scan and we go, oh, you've got a degenerate disc and you've got some disc bulges. That must be the cause of your pain. And so for this guy, waking up on the floor of school camp, within months he's got a diagnosis of arthritis. He's seen an orthopedic surgeon who says that his back is degenerating. This guy's 40. And all of a sudden, he's staring down this line of, this is it. I'm degenerating, I'm 40, and what does that mean? I've got to preserve this back of mine. So what do? I stop doing stuff. I don't bend, I don't lift, I stop exercising, I put on weight, I'm stressed, I can't sleep, and you can see this cascading process of pain and disability and fear that just drive this dreadful process that leaves this guy stuck. And that is such a common story. And so we look at this and you go, was that a mattress problem? Is there something about sleeping on the floor of school camp that's dangerous? Don't think so. And how relevant are these diagnoses? You see this stuff on a scan, this arthritis, this facet joint degeneration and disc changes. Like, what does that mean? And how does that happen when you sleep on a school camp, floor in a school camp? Did you get arthritic from sleeping on that mattress? And so these kinds of basic diagnoses actually make no sense to the person. If you actually ask them, how did that happen? Well, I don't really know. Doesn't make sense to me. And so we start looking at how are we treating pain in the Western world. And, you guys in the USA are probably the worst, actually. We're not far behind in Australia because we're chasing down the same rabbit hole. But if you look at the data around management of back pain, it's really disturbing. We have exponential increase in the amount of MR imaging for back pain. What is that telling us? It's telling us that we're finding stuff on scan we're blaming on pain. How predictive of those findings? They're not. What you see in a scan does not predict accurately how much pain you feel or how disabled you are or even your future history of back pain in any meaningful way. We have an increase in the opioid prescription rates, to a ridiculous amount. We are actually creating legalized addiction. We've got pushers who are actually prescribers. We have an increase in the sacral injections, and yet the long-term benefits of these injections are very limited. And we've got an increase in the fusion rates for back pain, even though the long-term benefits of a fusion or not show no greater benefit, but the risks are extraordinary and the costs are enormous. So what's happened with this is, unlike other health disorders, actually the disability burden of back pain is actually getting worse. So in spite of investing billions of dollars, and I was told yesterday $600 billion in this country for back pain, that is an enormous amount of money that is being spent on a disorder that is actually getting worse. So we've got to go, what the hell are we doing? And this is the kind of scenario I get to see when someone brings in their whole cascade of scans. And this guy just put him on the ground. I took a photo. I'm going, what the hell is that? I mean, how many times do you have to scan a back to look for something? And of course, that part of that is the desperation of the individual with pain, is I need to know why I hurt. And why are they looking at a scan? Because we have a belief, a cultural belief, that what you see on a scan will make sense to why you have pain. And the other image you see there is the end point of that disaster, with this poor disabled man with his whole spine completely fused, now opioid addicted, is profoundly disabled. He can't work, doesn't socialize, and that's the end point of that biomedical journey. Disaster. So no wonder we see, when you look at health disorders, all health disorders, back pain is the largest burden for disability of all health disorders. Of all health disorders, number one, that pops up. So where does it all begin? Well, if you look at the lifespan of human beings, it all begins very early for a lot of people. So during the adolescent growth phase, we see this exponential increase in the development of pain. At the age of 14, 45% of young people are reporting neck and back pain. The age of 17, that goes up to 70%, and that hits close to adult rates in the early 20s. We see these groups tracking through. If you track kids at the age of 14, around 10% are already reporting persistent back and neck pain, and that group tracks through right into early 20s. We see that, that trajectory of disabling pains hitting around 30%. So at the age of 17, around 20% of these young people are taking time off school, are taking drugs for their pain, are avoiding physical activity. They've got significant impairments. This is not an adult disorder. This is a disorder that can develop very early, and we start seeing this at that point in time. And the burden is held greater in females than in males. So we've tracked this through from adolescence into adulthood, and you see these trajectories. There's a trajectory, an increasing trajectory, a decreasing trajectory, and a continual trajectory that goes right through. And interestingly, what we see is an escalation in the amount of healthcare seeking as people go through into adulthood. There's an escalation in the amount of medication they take, the time off work and school, the functional impairment and the activity impairment that goes with it. So what we see is this emergent problem of pain where we start managing pain by doing what? Avoiding stuff. Work, activity, taking drugs, seeking healthcare. And we see an increasing burden of that develop over that period of time. So we're not doing a good job even with the kids. And that's shifting up into adulthood. And what we know from our data is that if you're taking time off school, guess what? You'll be taking time off work. So that behavior tracks through into adulthood. So when we start looking at back pain and say the story of Martin, we go, how does a human being who develops pain make sense of their pain? So what we know from health perception models is that, or illness perception models, is that we're all influenced. If you develop a symptom, say a back pain, what do? You fall back on your beliefs. You fall back on your cultural understanding of what is this? What are the social messages that we're getting and the context? And what are your previous pain experiences? What are the experiences of your mum and your dad? Because we know that if your mum and your dad avoid activity, take time off work, you're likely to do the same. So we learn our behaviours around pain from our peers, from our family contexts. And that's how we start to respond. And based on that, we go, what is it? What's the cause? What's the consequence? What's the timeline? Is this curable? How do I control it? Based on that, how do I respond to that emotionally? How do I act? What do I do? Do I take time off work? Do I avoid physical activity? Should I sit up straight? Should I work my core? Should I stop bending? That could be dangerous. And then does that work? So we see within this health model this whole process where a person has to kind of work out what the hell they're doing, what do they do about it, and you start seeing when you ask people with pain, how many people have you seen? I've seen 8 practitioners. What did you get? 8 diagnoses. What did they tell you? Pretty much all of them told me there's something wrong with my body, but it was all something different. How does that make you feel? It makes me feel like crap. Does that build your self-efficacy? No. Have you got any strategies to manage this yourself? No. I've had a lot of stuff done to me, but nothing I can do for myself. No wonder we're creating misery, if that's what we're doing in the health system. So we ask adolescents, what do you believe about back pain? This is people with no pain. This is adolescents with no back pain saying, what are your beliefs? 38% say back trouble will eventually stop you from participating in physical activity. This is people with no pain. 45% say later in life it will get progressively worse. 60% say back trouble should be rested. This is people, adolescents without any pain. So what do when they get pain? They fall back on their beliefs. That's what they do. So we've got a population out there thinking this stuff. It could be worse in your country. I don't know. I suspect it possibly is. Maybe not. So negative beliefs, we know, are associated with disability and care seeking. What do adults believe? Not so different. Adults with back pain believe that you've got to protect your back. Because why? Because it's got to be it's damaged. You're protected by resting. You're protected by being careful with avoiding dangerous activities like bending, like lifting, like being involved in sport, like playing with your kids, like living. You've got to strengthen those muscles. You've got to work your core. You've got to control your posture. They are the kinds of things that people with back pain think. So what underpins these beliefs? The great underpinning of these beliefs is that back pain is caused by injury and damage, and the back needs protected. It's vulnerable. It's a vulnerable structure. And so we start seeing these social messages that come out. You know, back pain's linked to damage and structure. Be careful when you bend. Don't bend your back. It's dangerous. Sit up straight because it's good for your back, isn't it? Work your core because a strong core will protect you. These are the kinds of messages that people fall back on. So what do we see? People with pain sitting up straight in misery, walking around pulling their bellies in, being fearful to bend, protecting and bracing themselves, just like the image you saw of that man when he was picking up his shoe. That is not a normal way to pick up a shoe. So the threat becomes a shoe. It's like, whoa, how did that happen? So this reflects common healthcare practitioner beliefs. It might reflect some beliefs in this room. But there's actually very little causal evidence for any of these beliefs. And I tell you, these are beliefs that I have held past my career. They're beliefs I was taught. And unraveling those beliefs is actually probably very important. So what do we know about back pain? We know that there is genetic predispositions to pain. And they're not around structure, they're around changes in the nervous system. We know that pain is more prevalent at times of rapid change, like adolescence, like pregnancy, like transitions through into menopause, like transitions from time of retirement. We see spikes of pain during rapid times of emotional, social, physiological change within the body. We know that how you respond to pain is influenced by your beliefs and your thoughts. It's influenced by your emotions. It's influenced by your social context. It's influenced by the things that you do and the way in which you load your body. It's influenced by your lifestyle. It's influenced by the other health comorbidities that you may or may not have. And based on this, that will impact on your body's structure. It will influence things like whether you develop inflammatory changes around an end plate of a disc. It will influence your nervous system. It will influence the motor system. So we see these profound changes that are impacted by these other factors, and that will have an impact on whether you become disabled or not. We know that there are people walking around the population who have back pain who never become disabled, and they will be predicted by these kinds of factors through here. The cool thing is that most of those factors, a number of them are modifiable. A number of them are changeable. And so the disability around pain can be influenced profoundly based on a combination of those things. And they become our targets of care when we start dealing with people with pain. So we look at people with back pain. This is a group of people with persistent back pain, around 300, that were investigated by Martin Raby, one of our PhD graduates. And he found that there were these three clusters of patients. And this is looking at their psychological profile. And this looked at things like their stress, their anxiety, their level of depression, pain catastrophizing, their self-efficacy. There was a group of people who had both high levels of emotional distress and very negative beliefs around their pain and low self-efficacy. There was a group who had predominantly negative beliefs around their pain and low self-efficacy, but not really, really high levels of distress, emotional distress. And there was a group who were low. And the interesting thing when you start profiling levels of emotional distress and your beliefs is you start seeing something that's quite interesting. The more distressed a human being becomes around pain, we see that their pain levels are higher. We see that they're more disabled. We see that they're more bothered by their pain. We see that they report more significant life stress events. So life stress events can have a profound impact on our nervous system as it tracks through time. Particularly early life stress factors can set a vulnerability through the lifespan. We see that they're more susceptible to increasing in pain with movement. We see they're more likely to report they feel perceptual differences in terms of where their body is in space. They're more sensitive to touch. They've got more undiagnosed comorbid symptoms like fatigue, dizziness, headache, migraine, and other symptoms. So we see that the higher the level of the stress, the higher the burden. And if you look at within the health system, the most disabled people, the people taking time off work, the people who are really in trouble are those who are really suffering from this problem. And of course, it goes two ways. You know, pain causes distress, and distress can cause pain and becomes part of that cycle. So within a clinical setting, we've got people who are coping really well. We've got a bunch of people who are pretty distressed with pain. We've got a bunch of people where they may have comorbid mental health problems. That just becomes part of that package. And when we look at something like taking time off work, we just got to finish the paper, that we've looked at people with mental health problems, like a diagnosed mental health problem, and we look at people with back pain. Both of those groups are likely to take more time off work. If they have the two of them, it has a multiplying effect. So you start combining them, it's just a bigger burden. So what about the things that people think? We know that there are so many people who are thinking terrible things, and that is not their fault. They've been told this stuff. They've been told their pelvis is out. They've been told their ribs are out. They've been told that their legs are long different. Their arches are collapsed. Their core is weak. That their bones are crumbling. That they're vulnerable. Now, why would you tell a vulnerable person they're vulnerable? It doesn't make sense. And so we rip out the confidence of people who are vulnerable by telling them that there's something wrong with their body. There may be something wrong with their nervous system, but to tell them there's something damaged with their structure does nothing but defeats them in that process. And so no wonder these patients are thinking bad stuff. No wonder they think they're going to end up in a wheelchair, or they won't be able to function, or they can't work, or they can't play with their kids, or they can't lift their child, or they can't have a baby, and all this stuff, because often they're told it. So what do we know about negative beliefs and fear and low levels of self-efficacy? It predicts disability. You know, when you're thinking this stuff, you behave like you're damaged, and of course you will if you believe it. And sadly, so often this comes from the negative information that we give. And I'm the first to put my hand up to say I have told people some dreadful things in my career. I've told people that if they do repetitive bending, the nucleus is going to pop out of their disc and they could be vulnerable. I can remember as a young physiotherapist in New Zealand, people coming in, I say, can you bend over? I go, I don't do that. I go, what do you mean you don't do that? Well, I don't do that because the disc could pop out. We have created that myth, and we've spread it, and it's on the internet. You can see graphic examples of when you load the disc, the nucleus squeezing out the back, or when you bend the back, that happens. People have these graphic images on their mind of the vulnerability of the human structure just to do normal stuff like putting on your shoes. So what do we see? People don't do that. Why would you? Why would you bend your back if your risk is your discal prolapse? Because that's the messages that we're giving. Vulnerability. You know, this is out of place. So words like chronic, what does it mean for someone? It's a death sentence. Words like instability. I've published my name linked to that word. Disaster. I say to people, even if you think it, don't say it. Even if you believe it, don't tell them it. because it can have devastating influence around the person's vulnerability they sense in their body. Wear and tear, it's rotting away. Like, these are things that we throw out, oh, it's just wear and tear. They're thinking car tire. Wear and tear, what do? I preserve it, or I got to change it. That's a disc replacement, or I can't use it, so I won't move. I'll lie down, I'll rest, I won't exercise. I don't want to wear that out because I've got another 40 years on this planet. That's what people think around that language, let alone MRI scans. My goodness, the language in an MRI scan is catastrophic. And you Google a term like disc degeneration, #1 hit for back pain when I Googled back pain in the US was, your back pain is caused by disc degeneration that will get worse with aging. If you're a 16-year-old and you happen to have an MRI scan, 45% of those 16-year-olds will find a degenerate disc. If that's what you're told, what the heck are you thinking you're going to look like when you're 60? So there's so much language that can do so much harm, and a lot of the language around backs is negative. It's dangerous. It's like danger. It creates fear. No wonder. And we go, oh, you're a catastrophizer. Where did that come from? We blame the individual, blame ourselves. We hold responsibility for the language that's used. Creates too much focus on structure, the belief that pain equals harm, the belief that activity is dangerous. You know, and so this kind of language around instability and a place, all the things we talked about, just increases the threat around pain linked to backs. So we start looking at what people who are fearful around back pain, and we ask them their story. We go, what are you frightened? So why are you frightened? There's a group of them saying, I'm frightened because I'm doing harm. Every time I feel my back pain, I think I'm doing damage. So what do? I protect it. I avoid stuff and I protect it. It's a natural consequence if you think you're damaging yourself. There's another group who are saying, well, I don't think I'm damaged, but that pain just scares the hell out of me. I'm frightened of pain. And I think we've created a culture that is frightened of pain. We tell kids, oh, be careful, don't climb on that, and oh, don't do that. And, we talked about backpacks. Don't carry the backpack because that could do you in. And we have a little wheelie bin. And like, what is that? We've created a frightened culture. People go, oh, don't hurt yourself because pain is bad. Pain is part of life. So if we ask people who are frightened, what creates fear? Fear is created when you can't control your pain, you don't understand the pain, you can't predict the pain, and the pain's severe. That freaks people out. Well, how do they respond to that? What do you do if you're frightened? You tense up. You protect yourself. You go into fight, fight, or flight. And usually it's fright. So that has a profound physiological impact on someone. That will activate your HPA axis, you activate your heart rate, you tense your muscles, you sensitize your system, you can alter your sense of perception of your body, and of course then you go, what are my options? I either sit at home and protect it to avoid it, or I might be thinking, damn it, I'm just going to carry on. But the carrying on is often around guarding the hell out of yourself while you do it. So you will protect yourself when you carry on. It's not normal carrying on. So you look at people with back pain when they move, they don't move normally. They move stiff and guarded and protected and premeditated because they're looking after that structure while they go about their business. Now we know that people with back pain can present with different profiles. Some people when they move may not have pain at all. Others are sensitized to forward bending, others to backward bending, others to forward and backward bending. And when Martin Raby looked at these kinds of profiles, he found some interesting things. Forward bending is the most feared thing for people with back pain. And so when people who had pain with forward bending were more disabled, had more catastrophic thoughts, and were slower in their movement. No surprise there. Look at all the messages around, don't bend your back. We've created a fear around bending. Look at ergonomic guidelines. What do we tell people when they go into a work situation? Be careful with your back. If you bend your back, you're going to do your disc. Don't round your back. Keep your core straight. People who are sensitized to both directions report more pain, lower pain thresholds, more likely to be depressed, lower self-efficacy. You know, they've got pain in any way that which they move. So you'll start seeing that the things that we observe in a clinical setting have got the biological and the psychosocial completely blended. You can't separate them. We love to dichotomize. Oh, well, that person's got a red flag, and that one's got a green flag, and the blue flag, and the yellow flag, and the brown flag's over there. And you know, those are all part of the same human being. Like the human being in pain who's sensitized, who's frightened, who's distressed, also has pain when they move. You can't separate those things. So what about behavior? Well, if you look at people with back pain when they move, what do they tell us? They tell us things like this: the most mundane activities of daily living have gone from being unconscious to being planned, fearful, and threatening. What a horrible way to live. To have to plan everything, to feel threatened with every time you go to bend down, do up your shoes, get out of a chair, roll over in bed. And we heard this story last night. This man's waking up every 2 hours in pain, and he's got to log roll himself into another position. He's cast like a stone into one position. He's frightened to move. Can't twist his back because it hurts, and he could flare up and it could last for 2 weeks. That's fear. So what does the body do when you're frightened? It protects, it guards. It will bolt you down. So what do we know about people with back pain? They move slower, stiffer, and with less variability. How the hell do we get into this core stability thing then? Because what we know about people with back pain, they use more core. They co-contract more. Their back muscles don't relax. They brace more. They generate more intra-abdominal pressure. How do we get sold this core stability story? When you look at people with pain, they're not floppy. Oh, wandering around, a little bit loose here. They're moving like a brick. Clenched fist in the back, walking around, clenched the fist, going, you know, it's really painful to move. It's like, well, I'm not surprised. Why do they do that? Because they're frightened. So we see a strong correlation between levels of co-contraction in the back and the level of fear you have. If you're frightened, what do? You tense up, you protect yourself. So when we look at people with pain, though, they can look pretty different. So, you know, some people brace themselves into flexion, others brace themselves into extension. Both can be painful in different parts of the zone. The irony is, the amazing thing is often we brace ourselves into the direction that we hurt. That's interesting. Now, why would we do that? Why would you brace yourself into the direction that's sensitized? So if you're sensitized to extension, you hold yourself in extension. Why would you do that? Because you've been told to? Because you fall back on your cultural beliefs? Because sitting up straight's good, isn't it? Does it feel good? Not really. It's got to be good for me, because it's surely not good to bend, is it? Or is it? Well, I get great relief when I lie on my back and bring my knees to my chest, but I'd never bend over because that's dangerous. And you just hear these extraordinary contradictions. Or you go, you telling me you love flexion, but you wouldn't do it? No, because it's dangerous. I've been told I shouldn't do it. So you see that fear drives behavior. Not even the own body telling you something. So we start looking at people with back pain, and when they do go about a lifting task, what do you see? People with back pain move stiffer, with more co-contraction, with high levels of compressive loading through their spine and more shear stress. So more upright, more co-contraction, more compressive loading. So why would you be doing a core exercise program for that group? They're already doing it. They're beating you to it. And we start looking at lifestyle factors. You know, these are often like a kind of response to pain. People stop moving. They exercise less. They're distressed, and they're like, don't know what to do. So we commonly hear they put on heaps of weight because they will use food as a mechanism of dealing with their distress. They often can't sleep, and we know that these factors, lack of sleep, increased abdominal obesity, inactivity, increases the inflammatory load in the system. It can influence things like your pain pressure, your pain thresholds, your influence the immune system. It can impact on body structure. And we look within a clinical setting, there are these kind of spectrums that we see. For some people, the pain is relatively localized. For others, it's more widespread. The more widespread pain, the more disproportionate pain responses to movement carries the load with more distress. So there's this whole interplay around that. So you'll tend to see the people who are most sensitized are the most distressed. The ones you can't touch, the other ones are really freaking out. And so it kind of becomes this really self-feeding trap. The more distressed you are, the more frightened you are, more sensitized you are, more likely you are to hurt when you do stuff which tells you shouldn't do it because you're thinking you're damaged, so you just get stuck. And so you start seeing studies around people who have been put in an fMRI scanner and going, look at this picture, now look at this picture, and they're going, oh, I can't look at that picture, that's terrible. I feel pain when I look at that picture. And so these group of people felt pain when they look at someone lifting awkwardly. And this is activation of the prefrontal region, areas linked to emotional responses to pain. We also see that people can report altered body perceptions, and some of Ben Wan's work has highlighted this, and we've been doing some partnering with him, looking at altered body perception. People who feel something's wrong with their body, something's out of place. And of course, there are certain healthcare practitioners who really milk this. They go, yeah, you are in place, the pelvis out, and the thorax is out, and this is out. And what does that do? It just reinforces the distress. Because who's vulnerable to thinking they're out of place? Distressed people are. And so what do? We reinforce it. What does that do? Good for business, bad for health. They become dependent on you to put you back in again. And you go, what's driving the perception of being out of place? It's when you're distressed. The brain doesn't quite know where it is when you're distressed. And so what do? We reinforce it. Crazy stuff. So discrepancies between the real and virtual body may act as a danger signal to the brain, and that could be a response. The response to that could be pain. The body will create pain when it's threatened to protect something. And so we see that this kind of just becomes a self-feeding cycle. And that's why we start seeing in the literature, you'll be very familiar with this work, is that all these different levels of changes within the central nervous system in the presence of persistent pain. And these things are way more predictive than what you see in an MRI scan. And they're essentially associated with sensitization of structures around the back. So we look at someone like Martin, you go, how did he end up with a chronic disabling problem when he just slept on the floor at a school camp? What's his story? Well, he had a certain amount of social conditioning. He was stressed out. He was organising the school camp. He was stressed out at the school camp. He didn't sleep at the school camp. He was working the week leading up to the school camp. And then when he had a crappy night's sleep, and when he developed pain, he's the kind of guy who had low self-efficacy. So he didn't just think, yeah, no worries, I'll go for a walk, I'll be fine. He worried, so he went and saw a healthcare practitioner who did what physios do and push on your back and loosen up. Felt a bit better, but it didn't go away. He worried again, so he went and saw his doctor. He got a scan. What did he get told? He's got arthritis. So at the end of that point of seeing the surgeon and the doctor and getting a scan, he's thinking, I'm damaged, I've got arthritis, I'm disabled, that's a life sentence, I've got no cure. What's his action? I'll avoid it and protect it to preserve myself. How does it make him feel? Terrible. Distressed, fearful, anxious, depressed, hypervigilant, he's trapped. And you can see how that health system trapped him by giving him the wrong messages and the wrong advice, and then this guy's just stuck in this cycle. So we start profiling that. This guy's now got highly sensitized back. He's emotionally distressed. He's got some really unhelpful beliefs that have been entirely driven by the health system. He's become socially isolated. He's physically incapacitated. He's not active, and that's impacting on his health comorbidities. The one thing he hasn't got, which is his diagnosis, is a pathoanatomical problem. The one thing in that profile he doesn't have is what he's been told he's got. He's got a normal looking spine for someone of his age. And that's the sad bit. So the bit that's being focused on is the bit he doesn't get, he doesn't have. So when we start asking physiotherapists what they think about, how they feel about saying to someone, how do you feel about that? Tell me about your journey. How's that impacting on your life? They don't want to go there. So physio's going, I deal with the physical stuff. So physical therapists only partly recognise the role of psychosocial factors in pain. They stigmatise patients with psychosocial factors as demanding and attention-seeking. They questioning and screening for psych factors they consider beyond their scope of practice. They lack confidence in dealing with psychosocial factors. Well, no wonder we have a problem. And I hear this all the time, oh, you know, you're trying to be a psychologist. I'm going, I'm trying to treat this person like a human being, like I would want to be treated, with respect and empathy and care and consideration. I want to know what you're thinking. Because for me to take you on a journey, I need to know what's going on in your head. So we must screen our patients. So with lots of screening tools. They're not perfect, and nothing beats a good interview. But we must be screening for these factors, because the disabled people are distressed and they're thinking stuff that's really not helpful and they're not coping. We need to form relationships with our patients, listen to their story, provide empathy, reflect, listen, identify discrepancy, reinforce positive health behaviours, acknowledge and summarise. In our examinations, we need a broader understanding of pain. We need to be considering all of these factors that are important around pain. It is not enough to tick boxes and ask about signs and symptoms. We need to be understanding their beliefs and their emotional distress and the impact that pain has upon their lives and where they want to go in their life. What is important to them? What are their values? We need to spend way less time doing all these ridiculous tests that do and predict nothing, to consider people's sensory profile, analyze the things that are important to them, look at ways of getting them out of trouble and take them back to the things that they love. So that's why when we start looking at behavior change, we go, how can you take someone? Huh? Are you kidding me? I want a picture of me on that escalator. You've got to take me there. Like, how do you get someone to walk the stairs when they're being offered an MRI scan and a needle and an injection and opioids? How do you get people to take that other journey? Because it's damn hard. So that's why we see this as it's an integrated approach. This is not just about your thoughts, it's about your thoughts and your behaviours and your lifestyle and all of these factors. We don't need to do more than just targeting pain. We've got to target functional recovery, we've got to target quality of life. People need both. We've got to be aware that this journey is based on, very importantly, a therapeutic alliance. We can't intervene with people without a relationship. We need to know that a relationship is influenced by confidence, listening, empathy, friendliness, encouragement, non-verbal communication. We need to consider that we educate our people. We need expertise. We need to be individualized. We need to take patient preferences into account. We need time. The journey looks like, first, we've got to make sense. You know, these diagnostic labels are redundant and useless and unhelpful that we use. You know, hypermobility, instability, dysfunction, impairment, derangement, all the stuff that we dump a label on are just so unhelpful because they don't reflect the complexity of the disorder and they don't give the person insight into how they can manage it. We need to take people back to the things that they love with confidence and with control. And we need to help people to manage their life, to address lifestyle factors. So we see this as kind of like an integrated journey of first saying, how can we help you make sense of this problem? How can we take the elements of your story and put it back to make sense for you? Well, you go, it makes no sense and I hurt my back lying in the floor of school camp, but it makes total sense if I understand the context of that situation. That makes sense. And people get it. When they understand it, they go, I get it. It makes sense to me. If you can make sense of your problem, you have an ability to become a partner in that journey. So reassurance is just not going, oh, you'll be fine. It's to say, hey, if you understand this problem and we give you a strategy, that's incredibly reassuring. But if you're just given a diagnostic label and say you'll be fine, that is not reassuring. Challenging beliefs and thoughts and responses to pain is a very challenging process, and so we need good motivational interviewing techniques, reflective questioning, behavioral learning. We use a lot of experimental learning Goal setting, target behavior change. There's a lot of language we could use that's positive, that's simple, that's understandable. We can use metaphors. We want to use language that reduces fear, that builds hope and confidence. We want to use language that dispels this idea that pain equals damage. Physical activity is wonderful. So we need to change the story around backs, that people start thinking that movement is good, that if it hurts, you have options. You don't have to panic and tense. You can relax and move. That I'm not damaged when I'm sore, I'm sensitized. That these structures are extraordinarily strong. They are capable of doing extraordinary things. That it's safe to bend, it's safe to relax. You don't have to pull your belly in and sit up straight. You can relax and slouch and cross your legs and put your foot up on the couch. Do whatever you want, because that's normal. So taking people back to scary things is a real challenge, and it demands a lot of confidence on the part of the therapist. So we use behavioural experiments to enhance pain controllability. We take people back to the things that are hurt, feared, and avoided. We focus on body relaxation and normalization of movement. We don't have rules around what is good and bad for the body. We say what is sensitizing, what is distressing. We'll take you back to that in a kind and gentle way. We normalize body perception. We provide feedback through mirrors, through video, to reassure people that actually movement is good. We build self-efficacy. And then we take people back to doing the things they love. What is it? Playing with your kids, lifting your child, kicking a ball, riding a bike. Whatever you want to do are the things that will take you back to. We'll gradually expose you to build your confidence, reduce your threat, recondition you where indicated. We'll deal with lifestyle factors around your sleep habits, activity levels based on preference, set goals. So what evidence do we have to this approach? There's 2 more trials that are just being conducted that haven't yet been published. There's one original study based in Norway that took a group of people and took them through this kind of approach versus a traditional physiotherapy, kind of manual therapy, core exercise, activation, general exercise approach. And this was a 3-month intervention with a 12-month follow-up, and both groups had exactly the same amount of treatment. So you see the outcomes here. This is looking at disability. The change in disability for the green box is the manual therapy exercise group. They showed a shift and a reduction in disability about consistent with what most conservative programs show. The shift was significantly greater in the CFT arm. And was maintained at 15 months. We saw the same shift in terms of reductions in pain intensity. We saw a reduction in the number of episodes that people had, a reduction in their fear. We saw a reduction in an improvement in their mood, and a reduced need for ongoing treatment. They were 3 times less likely to take time off work when they were taken through that journey. 12 months later, they were highly satisfied with the treatment. 3-year follow-up shows that they're still going well. Kieran O'Sullivan published a paper in Physical Therapy last year, taking a group of people off the pain clinic wait list. So people were waiting, they'd kind of dropped out of primary care, were now waiting to see the pain doctor with an ODI of 40, pretty disabled group. He tracked them for 3 months. You see they didn't change, and then intervened with them. They had a massive reduction in disability. 80% of those people didn't end up seeing the pain doctor. And then that was maintained 3 months later. And now we've got secondary RCTs with high disability groups. We're putting these interventions in towards pain clinics. And we look at the effect sizes. The effect size of surgery for back pain is shocking, actually. It's shockingly small. 0 is no effect, and just off 0. The effect size for behavioural treatment's moderate. Opioids is really not good at all. Why the hell are we doing that? Exercise manual therapy is moderate. Multi-disc care, that means putting everyone together, is kind of moderate. CFT at the moment looking like it's really, really good. We've got to do replication studies. Now, the interesting thing about this kind of intervention is really pretty simple. Conceptually it's simple. It's delivered by one therapist who will integrate the bio and the psychosocial, map it out and set a plan and take people back to the things they love. And that's why we think it seems to be quite effective. because it actually empowers the person to be in charge of their health. So that's why we have replication studies. And we've done qualitative analyses of people who've gone through this kind of process. We see, they say key themes, that I get it. I understand that my pain is not because I'm damaged. There are other factors. I've developed ways to take control of my pain and get back to the things I love. People who don't respond think they're damaged still, they don't have control, and they're still disabled. They're a group of in-between people. So what about Martin's story? So if we listen to Martin...
That made a difference.
Hang on.
What he said to me, that made a difference. He didn't really spend a lot of time doing what physiotherapists would generally do, which is manipulate you and move you around. He helped me to understand that the pain was ongoing because I had come up with new ways to try and avoid hurting my back. He looked at my MRI scan. He told me that the condition of my back was not perfect, but he had seen people with far worse backs who could live reasonably pain-free. And that was really encouraging to hear that.
It would take a fair bit of courage to stop guarding yourself like that. Tell me how you moved towards changing the way you walked and guarded yourself so that essentially your back was freed up.
Well, there were a few things. One of the first questions he asked me was whether I could touch my toes. And I attempted to get as close to touching my toes as I could. Probably got my hands to about my knees, and then I had to give up because of the pain. And over the course of that first session, he asked me to try a few movements and reassured me that they were going to be safe. And at one point in the session, he asked me just to sit on a chair and lean forward. And then he asked me to see whether I could touch the floor from a sitting position. And then he just told me to stand up. Then he told me to look in the mirror, and I looked at myself touching my toes. 5 minutes after, I couldn't do it. And I just broke down and cried. I couldn't believe it.
That's true. He cried. So he thought he could never do that again. And the experience of him to safely relax his body and bend and touch his toes created this massive emotional response for him. Because he was coming in thinking he was damaged, and all of a sudden, his beliefs were disconfirmed. Why? Through realizing that actually it was safe to bend.
Take before it was having a more permanent effect on you?
Well, for me, the effects were fairly quick. On my second appointment to see him, which was a week later, I had noticeably less pain. When I started to bend forward and use those muscles that hadn't been used for a long time, the effect was fairly instant. Even in a week, it was probably half the pain that I had before, and within a month, it was really reduced. You know, I wasn't feeling pain during the day, maybe a little bit at night if it was a tough day.
And how are you now?
Well, it's been probably about 6 months since my last appointment with Peter, and there's only been 2 or 3 times when it's been quite sore. And the difference for me now is I didn't panic. Pain used to make me panic a lot, but now the mindset's very different. I have pain and I think, all right, I need to do some stretches. And 2 or 3 days of getting back into my stretches, things seem to be back to normal.
So that's a pretty cool insight. He goes, pain used to make me panic. I don't panic anymore. My mindset's different. I understand now if I get pain, I can relax and move and get going and it settles down. Before I would panic and guard and protect and think I'm damaged. Now I don't think that. That's the journey that is such an important journey to take your people with pain in, I think. So what we understand from this is that we're changing his common sense model of pain. Instead of thinking I'm damaged, the mindset's different. Pain doesn't equal damage. Pain's related to contextual factors. So what Martin realized, when he's stressed and tired and run down, he's more vulnerable, he can get pain. So he goes, get some sleep, get active, get moving. So now he realized that back pain is just about sensitivity. It's about being tense. It's not about being disabled in a life sentence. He's got a great prognosis, and this is something that's manageable. So instead of protecting and avoiding, he stays engaged and doesn't protect. So how does that make him feel? He can stay cool and calm and relaxed and positive because he knows that that problem will not threaten his future. Does it work? Yes, it's wonderful. Means that he hasn't sought healthcare now for 3 years, but I tell you, he's sent a lot of his friends. So that changes the cycle. Instead of a vicious cycle, this becomes a positive cycle, a reinforcement, a re-engagement, reconnecting to his social networks, engaged in physical activity and healthy lifestyle. So what we see in terms of this complexity profile when he first presented starts looking like this. He's still got, a tendency to be relatively more anxious and a little less and confident than maybe he should. He's still got some of those factors, but generally he's doing well. So there are limitations with this approach. One is time, one is the amount of training, one is changing how you think, one is providing opportunities to change for people, and the big one probably is the mindset of the therapist. I've got to acknowledge a whole bunch of people I'm linked to. So I'm a very fortunate guy. I have a wonderful team of people who support me in the work that I'm doing, and these are both people I work with at Curtin University, nationally and internationally, and so I want to recognize all of these people and their contribution for the work that we're involved in. Also want to highlight that we have a website that's an open access website. We post the work that we do on that website. There are patient stories around in that website that we use to people can send patients to kind of develop a sense of confidence that actually there is a different path that you can walk than the path that's provided so often in the healthcare system. I'd like to thank you very much for your attention, and thanks for inviting me here, and I hope you enjoy the rest of your 2 days. Yeah.
Okay, so we've got about 15 to 20 minutes for some question and answers. And I mean, we're lucky enough to have a teacher that can also do. So if you have a question, please raise your hands. First question right here in the back. Ruth.
Hi, Dr. Sullivan. I'm Ruth Warner, and I'm very honored to have seen your presentation. Oh, thank you. For myself, I'm lucky to say I have not ever experienced long-term problems with my back, but I have people in my life, obviously, who do. And here's a story I hear a lot. I'm in so much pain. I know it would be better if I did my exercises, but somehow I just never seem to get around to that. And so to me, that's a self-efficacy thing, but I'm wondering, what you have encountered about that kind of resistance in self-care?
Yep, I mean, pain is very aversive. It's an aversive experience. It's a powerful motivator of behavior. I think that's around motivational interviewing. The question then is how important and how big a problem is this pain to you? So, it's a really big problem. How's it impacting on your life? Well, it means that, when I exercise, I hurt. So if you exercise and you're hurting, it's quite aversive. So if it's not that, then the question then comes down to saying, if they're saying, I feel better when I exercise, but I don't because I really can't be bothered, that's a different question. So then I'd be saying, well, how important is this pain problem to you? How much is it bothering you? Is it bothering you enough to stop you doing the things you love? Because if you're steering people to the things they love, if they love knitting and sewing and eating and watching TV, then that's a slight problem. Then you've got to take a different angle. And I say things like, do you brush your teeth? They go, yeah, I brush my teeth. Do you enjoy it? Not really. Why do you do it? Well, because it's good for my health. So physical activity is really important for your health. And it's not just important for your skeletal health. It's important for your mental health. It's important for your social health. It's important for your cardiovascular health. So maybe thinking of it not as an option, but as just an important part of life is another way of looking at it. Very often we see that pain becomes a barrier, but then people think of it as an option. And I think it's the escalator and the stairs. How do you get people to take the stairs? And that really comes down to human choice, actually. But you want to give people every opportunity to make that choice.
Good. Question in the back.
Hey, Professor O'Sullivan, thank you so much for coming all the way this side. My name is Dan King. I'm a professor at George Fox University, and I have a question. You said something about the therapist mindset, that that's one of the obstacles that
Yeah.
we have. So one of the things that I see, or if you can speak on, is specific versus non-specific
Yeah.
low back pain, or mechanical versus non-mechanical.
Yeah, yeah. The word non-specific back pain, we never would tell a patient that. Never. So the categorization really is taken from a research perspective to say, have you got something on a scan, like a tumor or a nerve compression or a fracture, that can be clearly correlated with the patient's clinical presentation or not? If you don't, then you fall into this grey zone, which is called non-specific back pain. That's really a default and a failure of our system to realize that actually, so Martin, this guy has so-called non-specific back pain, but it's very specific. He's highly sensitized in certain structures, and it's linked to a whole bunch of factors that we can identify, that we can clearly articulate to him. So I would never tell him his pain is non-specific. I'd sit down and say, hey, these things are all multifactorial. And actually, you've got a really sensitized structure for a bunch of reasons. One is you're holding the crap out of your spine, locking yourself into hyperextension because you're frightened, and that's really sensitizing those structures. 2, you're not moving. 3, you're not relaxing. 4, you're freaking out and you're not sleeping. So that is going to really wind up your nervous system. That is not non-specific back pain. That is a specific disorder linked to a bunch of multiple factors. And I think giving people these diagnostic labels is really unhelpful. Giving people a multidimensional explanation is really helpful. So we think you've got to change the label system around back pain to say, hey, the cool thing is it doesn't look like your scan's your problem. But actually, there's a whole bunch of things we've identified in your story that you can change, that can make an impact on your health. That's where we're going to go. And so sitting down, as you've seen the last 2 days, where you articulate and go, does that make sense? And they go, got it. So what in that can you change? I can change A, B, C, and D. Cool, that means you're on a journey. So those diagnostic labels are not helpful. The second question was mechanical, non-mechanical, not very helpful again. So if you followed any of my work, you might have seen that we kind of evolved over time. We used to think in terms of subgroups. We don't do that anymore. So the idea of subgrouping people or boxing them is actually not helpful. The best description of subgrouping I've seen was by a guy called Sapolsky, who I think's at Stanford, and he said we describe a rainbow in terms of 7 colors, but actually there's a million colors in a rainbow. We just describe them as 7 because it's easy to communicate what a rainbow looks like. So in the same way of pain, we have profiles. You have profiles of tissue sensitivity. You've got profiles of movement. You've got profiles of mood. You've got profiles in terms of levels of physical activity and sleep. And those profiles we can look at across multiple dimensions. Every human being will have a profile that's different to someone else. So we look at characterizing pain, not in boxes, but in terms of profiling across multiple dimensions. It's so much more helpful both for us as clinicians and also for patients. They don't feel boxed and wedged into one category. It's a long answer, I know, but it's a great question.
Can you come to Oregon and teach us that?
Yeah, sure. Actually, I've got a cool story about Oregon. Was that Oregon, John? We were kayaking, John and I were kayaking down a river in Oregon in a tent. This big bear came out, and it was like, when we were in the tent, this bloody big bear was out, and he was like, got onto the food, and we're like going, ate the honey, ate the butter, and we're like, don't eat us. So I'll just make sure I bring my bear protector.
We had a question over here. Jody?
My name is Jody Hutchinson. I'm a massage therapist, and I'm
Yeah.
the spouse of a low back pain patient.
Yeah.
My wife has had 3 spinal surgeries. The last one was a very intense AP fusion last June.
Yeah.
How can I, as a spouse, be a good caregiver but not
Yeah.
do myself in?
You know, yeah, it's such a... Look, you can't... Look, you can be a supporter, but you can't be the caregiver. I don't treat family members, and it's so important that you don't, because it just creates this whole mixed package. And it's, to be living with someone who's profoundly disabled carries its burden, and I'm sure you know what that feels like. And that's a tough that's tough. But making sure that you can link your wife to people who are empowering and positive and supportive, that can set a path, that she can take control in pain, is really important. We see a lot of people post-surgery, and it's the interesting thing around surgery is like once it's fused. Like, you know, treat it like a normal back.
She's
But
just
people
stiffer than hell.
walk around like they're still damaged even though it's fused. So a lot of that stuff is enduring. You know, it's like then they go, oh, but the next level. You know, oh, the surgeon said, well, you got to protect your back and don't bend because you can start, you know, that's going to go up. We're going to have to do the next one. You know, you just create this other fear. You know, it's enough to freak them out by having your back chopped, but then to freak them out, think, oh my God, I've got to protect the ones above. And the crazy thing is, the more you protect, the more you load, the less you move, the faster you're going to get unwell in those regions of the body. So, you know, that we work with people who have had multiple fusions and say, hey, just treat that like a normal part of your body. But having a partnership with people who can take someone on that journey is so important. So that's what I would encourage you to do. Now, in terms of how you support someone on that journey, it's hard if they're being channeled down a medication route or a passive dependency route. But if they're not, then it's much easier.
The surgeon was actually very kind and said, I'll have you off the pain meds in 3 months.
Awesome.
And that worked. He said, you can go skiing in a year if you want.
Awesome. So that's
we don't
good.
ski, but yeah. So,
So
we've
that's
been lucky.
great. So that's great.
Yeah.
Because that can be really undo people. Cool.
Question in the back, Eric? Yeah, we got a microphone right over here.
Hey, Peter. Ray posted a thing on Facebook that you were talking about nerve compression and how nerve compression did not cause pain, but inflammation does. But you don't tell your patients that inflammation causes pain, right?
Well, if it's an acute inflammatory sciatica, it's an inflammatory process
Sounds
around
like
the nerve.
nocebo to me, too.
Sorry?
Sounds like nocebo to me, too.
I think it's honest. It's actually good. It's good evidence. I mean, if you sprain your ankle acutely, you got inflammation around your ankle, do you say it's not inflammation? It doesn't mean it's damaging. It doesn't mean it's threatening. So I think it's what you take from something. You know, if you're sensitized around a structure, that doesn't mean you don't move. It doesn't mean you use it. It doesn't mean it's going to be damaged.
I just don't see the difference in telling them. What do they know about inflammation? So what's the same as telling them that they have a disc to me? I mean, I don't see the difference.
Yeah,
do they know what inflammation
I
is?
suppose it depends on how you interpret that. So I don't see chemical change around sensitized structures as a threat. It's changeable, it's modifiable.
They go home to their husband and say, man, I've got a lot of inflammation, you know, and then they start relating that to what they hear about inflammation
okay, but that
and
depends on
fibromyalgia.
okay, that comes down to your mindset of understanding of what that means. So
Mine or theirs?
both. But that's our job to be educators. So if someone has, you know, I'd be saying the benefit of, you know, managing pain is about engagement and activation of understanding that these things resolve. Natural history of sciatica is fantastic. You can have massive prolapse that will completely resolve within a period of, you know, weeks to 2 or 3 months. That is the threat around prolapse is people are thinking I've got pinched nerves that are crushed and you know that's around a sensitized nerve. It's not around a compressed nerve. So I will talk about the nerve being sensitized.
Yeah, I get that.
That's the same.
Okay, thank you.
We need a microphone way over here on the, and then our next question will be up here in the front row.
Thank you. Hi, my name's Raven Trevelyan. I'm a massage therapist in Seattle. I work with populations that a lot of times have been told that their symptoms are all in their head, or they've been accused overtly or covertly of malingering.
Yeah.
So a lot of people are very attached to a nocebic definition because it's an objective evidence that they are not malingering. I wondered if you've had to approach that in your practice and if you had any tips.
Yeah, it's very important. I mean, it comes down to this issue of validation. So validation is probably one of the most important things you can give your patient, is that your pain is absolutely real. It's a real experience. That the distress that goes with pain, your concern around pain, your fear of pain is a valid experience. And I think when people aren't validated, that creates a huge amount of resistance. telling people that their pain is in the head is profoundly unhelpful. And, there's a huge amount of kickback to that because it makes people feel like they're not validated. And I think, so, it's almost like a default that if you don't feel validated, you've been told it's in your head, then you default back to hanging on to something that's tangible. The really hard thing about diagnostic labels, and that's what we want. People want a diagnostic label. It's really frustrating for them if they don't. So there's almost this relief if they find something on a scan because then they've got a diagnostic label they can hold on to. The problem with that position is it leaves you with nowhere to go because then you become defined by this structural pathology. And so there's a middle ground in that space around it's not, this is not, you have a valid problem. But to shift them away from thinking that they're damaged is terribly important to build someone's confidence to manage their problem, but to not invalidate them to tell you this is just something in their head. And that's where I think if you take the things out of their story, it is their story. You're not telling them something that's about in your head. You're actually taking the pieces of the puzzle from their story and you're putting it back. And I kind of see it like our patients come to us with a whole bunch of pieces in a puzzle in a box. They don't know what the puzzle looks like. They just know all the pieces are there. And so we take those pieces and we go, hey, do you see this picture? I can make this puzzle for you. Do you see that? And you show it to them and they go, that makes sense. Now, to say, oh, yeah, it's in your head, or it's about this, is just taking it's a piece that doesn't fit in the puzzle, actually. But actually, to take the pieces of their story and relay it back to them is very validating because it tells you you've listened, you've understood, you've interpreted, and you're relaying back. That takes a middle ground.
Thank you.
Right up front here.
Hi, I'm Alice Sambito. I'm a massage therapist, and I had a comment and a question. And the comment was, the photograph you had of the stairs with the elevator or escalators reminded me of a clinic that I studied at briefly in Latvia. And in the clinic, in the central part, there's this big, wide, beautiful staircase, and that was everybody's default way of getting from one floor to another, and people would meet each other on it. And there was an elevator, but it was way over in the corner, and people who couldn't negotiate the stairs would use the elevator. But the stairway was the default, and here it's the opposite, where the elevators are central and the stairs are in the corner, and they're kind of scary and hard to find. And I thought, brilliant to set it up to get people that's a default. The question I had was, earlier in your talk, you had some graphs about the incidence of low back pain, and it kind of starts pretty young, and then it kind of levels off. And the common conception is as you grow older, you're going to have more pain.
It's not true.
And I've seen that before, and I just wondered what you had to say about that.
Yeah, it's not true. So there are lots of really unhelpful beliefs around pain, like it gets worse as you get older. Actually, it tends to tail off. Probably other health problems become more dominant, and so the focus shifts somewhere else, I think. But actually, that peak is in the very early 20s, and it doesn't really go up much beyond that. And then it tends to tail off in later life. So this idea that as you get older, you get worse is just not true. But I tell you what, that's what people believe. And the devastating thing, and we're really interested in doing some research into the elderly population, because every person has stuff on a scan once you crack 45. Every person has it. So everyone's got a pathanatomical diagnosis, and they get told dreadful things like, oh, your back's stuffed, it's crumbling, it's bone on bone. Same story we hear for the knee or the hip or other parts of the body as well. And so that has a devastating impact on someone around. They may be struggling already with their self-efficacy and the struggle of like losing function as they get older, and then they're damned with this idea that they can't trust their body. I just think it's so horrible. But changing that understanding is terribly important. That if you look at the prevalence of pain across time, it doesn't do what we think it does. So it's a great point you highlight. Just on this issue of changing behaviour, we have a television. It's in the darkest, most miserable room of our house. So our kid never watches TV. And it's exactly the same as... if you stick your television in your living area, in the nicest part of your house, it'll be watched. Stick it in the crummiest part of your house and no one's interested. It's like your escalator.
We take one more. We've got one more question, and this is from one of our online participants. Catherine Schultmeyer asks, "Is there a large variability in the frequency or duration for your care plans using cognitive functional therapy?"
Oh, great question. Absolutely, it is. Yeah. So that's the journey. Everyone's journey is different. Everyone's journey into pain and disability is different. Everyone's journey out is different. That's why you have to be flexible. And it's around goal orientation. So that radar graph I showed you changes all the time. Pain fluctuates. You know, it's like we go, oh yeah, that's your trajectory. Back pain actually looks like asthma. So if you look at a health disorder such as asthma, it's characterized for some people by acute flares and settles down. For others, it's this undulating process. Back pain looks like that. And so pain will emerge at times as stress and change. And so the journey will kind of work with that person on that journey. For some people, they grab the opportunity and run. For others, they need partnership that takes time. Most of the intervention studies that we've been involved in have tended to work with people over 3 months. We think that's like a good time frame to shift people, but we wean people off. So we might see them more closely at the beginning, and we push the responsibility back to them and wean them off. But for others, they may need booster sessions down the track. For some, they got it in 3 sessions and they're away. And then we might check them 4 or 6 weeks and then 3 months down the track. But everyone's journey is individual. And that depends on social context, external factors, external stresses, demands, all kinds of things. We see people who've got massive social stress. They're caring for kids who've got depressive disorders, parents with Alzheimer's. They've got massive demands in their life. That will just make that journey tougher. So that just reflects us as human beings. That you consider the dimensions, you understand the journey looks different. So it's a great question.
Thank you very much.
Thanks, guys.
Professor O'Sullivan.